Hello? Narinig niyo ba ako?
Yes po, Doc.
Okay. Nakikita niyo yung slides?
Yes po.
Sige. Kakatapos lang ba ng lecture niyo? Do you wanna take a 5-minute break or diretso na natin?
Okay lang po, Doc, kahit diretso na po.
Okay. Good afternoon. I'm Dr. Aban, one of the residents in Psych residents in NCMH. So I'll be presenting this emergency psychiatry lecture. I would like to know lang if nagro-rotate kayo sa ER nung, of course, hindi kayo pumapasok, no? Or nakapasok na ba kayo simula nung nag-start yung clerkship or internship nyo? Well, anyway, sige. So, ang alam ko kasi may mga clerks before na nagro-rotate sa ER. So, probably familiar sila sa mga scenarios na mababanggit ko. Okay? So, let's start. Pero I'm clear. Okay, naririnig niyo ako?
Yes po, Doc.
Okay, sige. Okay din naman yung slides. Yan, nakikita niyo, no?
Yes po.
Okay. So, psychiatric emergencies, this pertains to any disturbance in behavior, in action, for which there is a need for an immediate therapeutic intervention. So, the primary goal of a psychiatric emergency is a timely assessment and disposition of the patient. Okay? So, ano yung scenarios usually na nangyayari sa psychiatric emergency service? So, we receive patients na walk-ins, of course, yung iba referrals from other hospitals, from other services. Okay, may mga tumatawag na ibang hospitals na refer nila o na-endorse nila sa amin yung mga patients nila for psychiatric evaluation. So, sa ER, dumadaan yung mga yon. Other cases are from police and ambulance cases. Usually, included dito yung ang nagdadala mga social workers na mga napupulot nila sa mga kalye, yung mga vagrant natin na nagkakos ng disturbance sa community. So, usually, nare-refer muna sila sa social worker at the barangay level and then, dinadala sa psychiatric emergency. Okay? So, upon entering the hospitals, pupunta sila sa triage. Iti-take yung vital signs, titingnan kung may old records, and then, the nurses will ask the reason for their consult. So, it depends sa reason ng consult nila kung emergency ba yung presentation or sa outpatient naman. So, if the nurses deem that the case is an emergency, so dadalhin na sila sa ER. So doon, sa triage din, ika-classify kung ano ba yung level ng emergency. So meron tayong mga category category 1, 2, 3, 4, 5. So, yun. Usually, yung mga disturbed needed ng immediate psychiatric evaluation, category 3. Category 4, yung hindi masyado needed ng psychiatric, yung hindi masyadong or less disturbed yung presentation ng patients. For those na mga cat 3, pwede yung immediately na madidim natin na admissible. Yung mga cat 4, some of it, most of it, hindi naman admissible, pero kailangan pa rin sa ER matingnan. Cat 5, outpatient cases yun. So, usually, may mga outpatient cases na nadadala sa ER kasi pwedeng nasaraduhan na ng outpatient, so sa ER na lang dinala kasi naabutan ng cut-off, o di kaya nagkaroon ng sudden work suspension. So yung mga service users natin from malalayong province na nakapag-travel na for their supposed outpatient consults ay hindi na natin pinapauwi yon dahil walang outpatient. So dinadala na lang sila sa ER para at least matingnan sila. Okay, cut 2, cut 1, usually those medical na siya. Walang psych history, medical. Kailangan lang siya ng tingnan ng medical wing ng ER. So sa atin, sa emergency room natin, meron tayong psychiatric wing and medical wing. So doon, natatarege din doon yung mga service users natin. So upon entry from the ER, i-evaluate siya muna kung medical ba to or purely psych. And then, if needed observation, kung kailangan ng medication, observe muna, and then pauwiin, yun yung ginagawa. And then, others, kung talagang highly disturbed naman yun, automatic, i-admit naman. So, that's the usual process when a patient came for psychiatric emergency evaluation. If you have any questions, you can just unmute yourself, no? Hindi ko kasi nakikita dito yung chat messages. Okay, so next. What are some general strategies in evaluating the patient in the ER? So first, we must consider self-protection. Self-protection, we prevent harm. Then we rule out non-psych etiologies and rule out any impending psychosis. So what are some strategies for self-protection? So know as much as possible about the patients before meeting them. How do we do this? Of course, through interview with the informant. No, either a relative or a social worker or anyone who brought them in the ER. Leave physical restraint procedures to those who are trained. Usually, these are the nursing service, the nurses and the nursing attendants. They have training for restraints, for physical restraints. Okay, hindi lang siya, kung nakakita na kayo na nire-restrain, no? Hindi lang siya basta tinatali. Hindi lang basta tinatali yung kamay paano. There are proper procedures to do that. And there are trainings for that. So be alert to risks of impending violence. We usually say we prioritize your safety first, no, and the safety of the patient. So we do the restraint so that the patient won't be able to do more harm to himself and to the other staff. Okay, attend to the safety of the physical surroundings. Have others present during the assessment if needed, have others in the vicinity, and attend to developing an alliance with the patient. Okay? Well, this will be difficult if kita naman natin na very disturbed, nagsisisigaw. So, we don't attempt na agad na mag-develop ng therapeutic alliance at that point. Okay? Ang priority natin doon, syempre, i-stabilize muna siya before we do the therapeutic alliance. How to prevent harm, prevent self-injury and suicide, use whatever methods are necessary to prevent patients from hurting themselves. So at the ER level, what we can do, of course, yung physical restraints. Prevent violence toward others. During the evaluation, briefly assess the patient for the risk of violence. If the risk is deemed significant, consider the following. Inform the patient that the violence is not acceptable. So we at least attempt a verbal de-escalation. Usually, or in some patients, nag-work siya, pero yun nga, if kita naman natin na nagsisigaw, nag-uula dyan, for sure, hindi na yun makakarating sa, hindi na niya maiintindihan yung sasabihin natin, no? Approach the patient in a non-threatening manner, reassure, calm, or assist the patient's reality testing, offer medication, inform the patient that restraint or seclusion will be used if necessary. So, ito yung mga forms ng verbal de-escalation. Have teams ready to restrain the patient. And when patients are restrained, always closely observe them and frequently check their vital signs. Isolate restrained patients from surrounding agitating stimuli. Immediately plan a further approach, medication, reassurance, and medical evaluation. Okay? And then we rule out na psychologies and impending psychosis. These are some features that point to a medical cause of a mental disorder. So not all patients who presents with behavioral disturbance ay caused by a primary psychiatric problem na agad. Okay? Others, kasi merong mga medical condition na nagko-cause ng mga behavioral disturbance. So, before we rule in or we lock in into a primary psychiatric disorder, kailangan muna tayong mag-rule out ng mga medical causes. So, ang sinasabi lang dito, what are some pwede makapagbigay sa atin ng clue na pwedeng medical cause yung medical ang nagko-cause ng behavioral disturbance. Okay? So first, if the behavioral disturbance occur in an acute onset, okay siya, not until within hours or minutes or few days before consult. Okay? First episode, psychosis. First episode, behavioral disturbance. Psychotic episode na nag-occur at older age. Patients who has current medical illness or injury, those who have significant substance abuse, those who have non-auditory disturbances of perception. So non-auditory kasi in a psychiatric illness, more common ang auditory hallucinations. So kung yan ay visual hallucinations, walang auditory, visual lang, o di kaya tactile hallucinations, we first look into a medical cause. So probably a tumor, seizure, or di kaya naman substance. Pwedeng alcohol. Okay? Neurologic symptoms such as patients who presents with neurologic symptoms such as loss of consciousness, seizures, head injury, change in headache pattern, change in vision. Those who have classic mental status signs such as diminished alertness, disorientation, memory impairment, impairment in concentration and attention, dyscalculia, and concreteness. Others, those who have disorders in speech, movement, or gait, baka neurologic pala yung cause niyan. Or those with constructional apraxia, difficulties in drawing a clock, cube, intersecting pentagons, Bender-Gestal test. So yan, ito lang definition ng psychosis, patient's degree of withdrawal from objective reality, level of affectivity, intellectual functioning, and degree of regression are other important parameters. All communication with patients must be straightforward, and all clinical intervention should be briefly explained using language the patient can understand. So these are some patients na usually nakikita natin sa ER, no? Those who has an ongoing psychosis, those who are depressed and has potential and are potentially suicidal. So for cases of depression and suicidal patients, we should always ask about suicidal ideas as part of the MSE. Okay, especially if the patient is depressed. Kahit psychotic nga may times na nagkakaroon sila ng suicidal ideas. So laging sinasabi sa amin ng mga consultants, kalimutan mo na lahat. Kalimutan mo na lahat ng itatanong. Wag lang suicidality, homicidality. Okay? What are some questions that you can ask? Are you or have you ever been suicidal? Do you want to die? Do you feel bad so you might hurt yourself? So something like that. Okay? A suicide note, family history of suicide or previous suicidal behavior na part of the patient increases the risk of suicide. If the physician decides that the patient is in imminent risk for suicidal behavior, the patient must be hospitalized or otherwise protected. So, of course, those patients na highly suicidal, offer na agad yan ng admission at the ER. Okay? Pero, for those patients who only have their first consult that time na suicidal, usually re-refuse sila ng admission. So, in cases like that, what we do, we have them sign a waiver para lang, of course, syempre protected tayo, no? So, what are some questions we ask about suicidal feelings and behaviors? So, we begin with questions to address the patient's feeling about living. So, have you ever felt that life was not worth living? Or did you ever wish you could go to sleep and just not wake up? And then we follow up with specific questions about thoughts of death, self-harm, or suicide, such as, is death something you have thought about recently, or have things ever reached to a point that you have thought of harming yourself, or something like that, no? And for those who have thoughts of self-harm, you can use the following questions, no? English lang yan, pero syempre, assess natin kung di naman marunong English yung patient natin, we translate this sa Tagalog. Okay? So, other terms lang to related to suicidal ideation and behavior. So, we have aborted suicide attempt. These are potentially self-injurious behavior with explicit or implicit evidence that the person intended to die but stopped the attempt before physical damage occurred. Mga naghang, ganon, no? O kaya nag-try mag-ingest. Common yan. Common sa ER natin yan, ingestion and hanging. Okay? Deliberate self-harm. So, ito yung mga naglaslas. No? Willful self-inflicting or of painful, destructive, or injurious acts without intent to die. Lethality of suicidal behavior. So, objective danger to life associated with a suicide method or action. Sorry. Note that this is distinct from and may not always coincide with the individual's expectation of what is medically dangerous. An ideation, these are thoughts lang of one's own death. Intent, there are subjective expectation and desire talaga to end life. Suicide attempt, there are already attempts. Nag-try na talaga siya for a self-injurious behavior. However, non-fatal yung outcome. Suicide, self-inflicted death. So, ito na yung complete suicide. Okay? So, in evaluating risk of suicide, we consider the following variables. So, in terms of age, those who are over 45 years, male, divorced, widowed, unemployed, had always conflictual interpersonal relationships, no? Have a chaotic family background, has chronic illness, those who have excessive substance use with severe untreated depression and psychosis, severe personality disorder, those are at high risk of attempting suicide. Okay? Those who have frequent, intense, prolonged suicidal ideation. And ito, the highest risk na pwedeng those who have multiple attempts na or previous suicide attempts, sila na yung mas higher risk into committing another suicide attempt. Okay? So, those with poor achievement, poor insight, poor rapport, socially isolated, yan. Very high risk sila for suicide. So, ito, naulit lang, no? History, signs, and symptoms of suicidal risk. So, ito lang yung kailangan nating elicit during our interview and history taking from our patients, no? Previous attempt or fantasized suicide, anxiety, depression, means of suicide, concern for effect of suicide on family members, verbalization of a suicidal ideation, kung may will na ba, resignation, proximal life crisis, family history of suicide, and pervasive pessimism. So other patients we see in the ER, of course, violent patients. So the psychiatric interview must include questions that attempt to sort out the differential for violent behavior and questions directed toward the prediction of violence. Best predictors for this: excessive alcohol intake, history of violent acts with arrest or criminal activity, and history of childhood abuse. How do we assess and predict a violent behavior? So these are some signs, no, of impending violence. There are recent acts of violence such as property violence. So dinala bawa from the community na narareklamo na kasi or dinala sa ER dahil nagsisira ng mga gamit, nagbubato, nagsisira ng mga nakaparadang sasakyan. So, yun. Verbal or physical threats, carrying weapons, progressive psychomotor agitation, alcohol or drug intoxication, persecutory ideation in a psychotic patient, commanding auditory hallucinations, those with mental disorders due to a medical condition such as frontal or temporal lobe findings, patients with catatonic excitement, those with mania, agitated depression, or personality disorders. So how do we assess the risk of violence? We consider the violent ideation, wish, intention, plan, or availability. Consider the demographics, the past history. So, of course, ito makukuha lang natin sa history taking. Okay? So, how do we treat these kinds of emergencies? Pharmacotherapy. No? Una na agad yan, especially for those na agitated patients na needed na physical restraints. We give na din chemical restraints, no? So these are some primary indications for psychotropic medication in the ER: violent, assaultive, massive anxiety or panic, EPS reactions such as dystonia and akathisia as a result of an adverse effect of a psychiatric drug. So yun, may mga cases din na pumupunta, no? Ang history naman yan, na-injection na ng long-acting injection few days before, tapos biglang naninigas, naglalaway, yun. Sa ER din ang bagsak ng mga yon. So those with anxiety and panic, yan. Hindi naman na-admit yung mga ganyan, pinapakalma lang sa ER. So in the ER, a high priority is given to the pharmacologic treatment of agitated patients to reduce the incidence of patient and staff injuries and to reduce the patient's psychological discomfort. So ganyan sabi ko, priority kasi safety. Kaya nabibigay na tayo ng pharmacologic treatment agad sa ER pa lang. What medications can we give for those with agitation due to a primary psychiatric illness? We have kung familiar kayo, no, risperidone na orally disintegrating tablet or the oral solution na risperidone. We also have the orally disintegrating olanzapine. So these are sorry. These are the first line intervention for agitation. Okay? But for those na severe ang agitation, na madidim natin na hindi naman sila magte-take ng oral meds. So yung sigaw ng sigaw as in very uncooperative, we can give injectables. Wala tayong IM ziprasidone, wala tayong IM lorazepam. What we have is the intramuscular haloperidol. Wala rin tayong IM na olanzapine. Okay, so usually haloperidol 5 mg, 1 cc binibigyan natin sa ER. So for those naman yung agitation is caused by a stimulant intoxication or alcohol withdrawal, we give benzodiazepines. We usually give diazepam sa ER. Oral medication should be attempted prior to IM or IV when possible. Okay? Those who have agitation due to alcohol or other CNS depressant intoxication, haloperidol pa rin. This is proved to be safest and has low concern for respiratory compromise. So siya yung first line niya. Second generation antipsychotics, either orally or IM, are alternatives such as ano yung mga SGA natin, risperidone, olanzapine. Benzos should be avoided due to risk of respiratory depression. So ito na, paulit-ulit ko ito nababanggit, no? Restraints. These are used when patients are so dangerous to themselves or to others that they pose a severe threat that cannot be controlled in any other way. Patients may be restrained temporarily to receive medications or for long periods if we cannot use medications. But usually, we restrain patients 2 to 4 hours, then we reassess. Kung kumalma naman na, i-release naman natin sila sa restraints. Kasi prolonged restraints can cause aspiration. So, we don't want that naman. Okay? At most, dapat 4 hours lang sila naka-restraints. So, use only after non-physical approaches fail. We still maintain the privacy and dignity of the patient. Limitation of movement should be non-restrictive as safely as possible. As I've mentioned kanina, there are personnel who are trained on doing proper restraints of our service users. The emergency department should set appropriate and consistent guidelines for restraints, including what treatments should be given, the monitoring necessary, and how the patient will be evaluated for ending the restraint. No? Kasi nga, hindi naman siya pwede talagang naka-restraint for a long period. The patient should be explicitly and continuously observed by the treatment team, and the use of physical restraint should be consistent with all standards and rules. So, meron naman tayong standards dito sa mental when it comes to restraining our patients. So, disposition. So, I've mentioned this, no, na ang priority when a service user came to the ER. So, timely assessment and disposition. Pauwiin niyo ba to? Tihok ba siya? Or admitin? Okay, so when the decision is to admit the patient to the hospital, it is preferable to do so voluntarily. Allowing patients that option gives them a sense of control over their lives and of participation in the treatment decisions. So usually, those service users na kita ba natin na very disturbed, no? Hindi sila makakapag-decide on their own. Ang nagbibigay ng consent for admission ay yung relatives. Okay? The kind of attention and concern showed to patients on arrival in the ER strongly affects how they will respond to staff members and treatment recommendations and even their treatment compliance long after they have left the emergency room. Okay? Okay, so documentation is always an important part of assessing our patient. No, the medical record should convey a concise picture of the patient, highlighting all pertinent positive and negatives. Gaps in information and the reason should be mentioned. An initial treatment plan or recommendation should follow from the findings of the patient's history, MSE, and other diagnostic tests and medical evaluation. So, yun. Kung familiar kayo doon sa case ni ano tawag dito? Ni Clancy, no, sa Facebook. Yung may pinatay niya yung, well, sabi sa pinatay niya yung 3 niyang anak, 'di ba? So during dun sa mga trials, sa hearings, nasilip kung how she documented the consultations. So sa psych, very very important 'yan, especially yun nga pag dumating ka na sa point na nagkakaroon ng ganitong legal cases. Especially sa ER kasi syempre ang laging sinasabi sa amin ng mga consultants niyan, sa pag-assess namin ng patients, admissible ba or hindi. So we always ina-assess namin talaga properly kung at this point the patient ba, lalo na yung mga suicidal, kailangan ba niya ng admission? Of course, kapag suicidal kasi automatic admission na yan, no? Kaya lang for those na nagre-refuse, dun papasok yung proper documentation, no? Para hindi babalik sa atin na, bakit pinauwi niyo to, no? Kita niyo naman na nag-complain ng commanding hallucinations or di kaya ng suicidal ideation, bakit pinauwi nyo? So, madedefend natin yon through proper documentation. Okay? So, very short lang tong lecture. Actually, that's the end of the presentation na. Do you have questions? Wala kayong questions. I hope may nakuha kayo na something dito sa short lecture natin. And yun lang. So mabilis lang, 30 minutes lang yung lecture, no. So kung wala na kayong questions, we can end this meeting, and thank you guys.
Thank you po,
Thank you
Doc.
po, Doc.